All right. Assalamu alaikum, everyone. I hope you're all doing well. My name is Rawad Turko, and today, inshallah, we're going to be doing some practice questions for your pathology discipline in your head and neck block. So, inshallah, it shouldn't be too long of a session. You only have 4 lectures. We're going to do a few cases, a few questions from each lecture. Inshallah, by the end of it, you should have a good understanding of all of the pathology in this block. So, let's just get straight into it. We're going to start with lecture 1, which is lesions of the oral cavity. Here's the first question. So, a 17-year-old girl notices a small, sensitive gray-white area forming along the lateral border of her tongue 2 days before the end of her final examinations. On examination by the physician's assistant, the girl is afebrile. There is a shallow, ulcerated 0.3 centimeter lesion with an erythematous rim. No specific therapy is given, and the lesion disappears within 2 weeks. The history shows that the girl does not use tobacco or alcohol. Which of the following is the most probable diagnosis? So, it's either A, aphthous ulcer, or B, herpes simplex stomatitis, C, leukoplakia, D, oral thrush, and E, sialadenitis. The answer is A. Okay, so let's just go over a few of the options. We'll talk about why it's not any of the other options, then we'll talk about aphthous ulcer. So why is it not herpes simplex? So with herpes, what you would get are multiple small ulcers with multinucleated giant cells on histo. But that's the key words, that you get multiple small ulcers. Okay, and they could be painful, but in this case, you only have the one ulcer. So we can rule out herpes simplex, or at least it's not as likely as aphthous. Then we have leukoplakia, which is a white patch. It's precancerous and it's associated with tobacco. So you wouldn't see this leukoplakia in a young patient, especially that she doesn't uh, use tobacco or alcohol. Oral thrush, usually you would see candidiasis, which is what oral thrush is, in immunosuppressed patients. So either somebody who has uh, yeah, so either has diabetes, somebody who takes any immunosuppressive medications, maybe a person with HIV, then you could see oral thrush. So sialadenitis is just completely unrelated. This is an inflammation of the salivary glands. I didn't finish the sentence here, but it just presents as you might have some systemic symptoms like fever. You're also going to get some pain wherever the gland would be. So salivary gland, it could be the parotid gland, so you get some cheek pain. So now let's talk about the aphthous ulcer. So aphthous ulcers, the classic vignette would be a 23-year-old woman presents with a painful mouth ulcer on the inner lower lip. She has had similar episodes, often triggered by stress. Exam shows a shallow ulcer with a gray base and red rim on a non-keratinized mucosa, no fever, or systemic symptoms. So aphthous ulcers, basically what they are these tiny little ulcers that you get in your mouth. Usually they come with stress or any stress-related episodes. And they usually just present as one lesion. Sometimes they can present as multiple lesions, but that's a separate thing. All right. So one ulcer usually would be a gray base surrounded by an erythematous rim, like a red rim, and they will mention that in the question. So this is very, very classic presentation of aphthous ulcer. So I wrote here some buzzwords for you guys to recognize aphthous ulcer if you guys see it on exams. So you have a painful, shallow oral ulcer, usually presenting as one ulcer, gray or white base with an erythematous rim. So you guys see here, if we take a closer look at the picture, you can see that it's a gray lesion surrounded by erythema. So this is the red rim that you see with an aphthous ulcer. Okay, usually they would be recurrent ulcers in healthy individuals. So in this case, just like we saw in our last question, the patient does not smoke or does not drink. Okay, so usually they don't have any classic risk factors, something that you might see in a lot of these oral lesions like tobacco usage or alcohol. You wouldn't see any of that in aphthous ulcer a lot of the times. No systemic symptoms because again, this is not an infection. This is more of an immune process and it's triggered by stress, trauma, or acidic foods, and it's self-limited. So you don't really have to do anything. They mentioned here in this last question, obviously, that she wasn't giving any specific therapy and the lesion disappeared within 2 weeks. So again, self-limiting, shallow ulcer, gray-white with where is it? With a red rim, yeah, erythematous rim, and no other risk factors, and self-limited. So again, this is just a little description from first aid. You guys can feel free to read that if you want. So this is our first question. Which of the following is a result of chronic irritation? So it's either 1, 2, 3, or 4. By the way, guys, I can't see your chats, so if you guys have an answer, just you can feel free to unmute and just answer. Okay, so the answer is two. So let's just go through each one of these pictures and take a look at what they are exactly. So for this first picture here, this is actually erythroplakia. And then the second picture is fibroma. This is oral thrush, and this is a pyogenic granuloma. Let's start with erythroplakia. So we know that erythroplakia, we saw it before, or you guys know it by now, that it's a precancerous patch, usually, presenting with similar risk factors like leukoplakia, and we'll talk about that shortly. But again, it's red, velvety, and it's non-scrappable patch. It has a very high risk of dysplasia and cancer, and it's associated with tobacco use. Okay, so this is not a result of chronic irritation. This is a precancerous lesion, if you see it right here. All right, oral thrush, we talked about it in the first question too, caused by Candida albicans. It's an usually it would be an immunosuppressed patient, okay? Rarely it can be in infants, but most generally speaking, you can see it in immunosuppressed patients. And it's a white scrappable plaque. This is very important. It'll show up on questions this white patch that can be scraped off. So that's what candidiasis would be. Pyogenic granuloma, it's a granulation tissue, bleeds easily, and it's with chronic inflammation or pregnancy. Now, a pyogenic granuloma, it's actually not just an oral lesion, so you can get very, very similar lesions. You also call them pyogenic granulomas in other places on the body. Sometimes you could get them on your fingers. But they always have the same presentation. So it's granulation tissue. Usually they are very, very heavily bleeding. They bleed a lot and they show up with chronic inflammation or pregnancy or with trauma. So if you get any trauma to that region, and then you get something that looks like this, you'll know that it's a pyogenic granuloma. Finally, a fibroma. So this is a painless reactive nodule. So when something is a reactive nodule, usually it means they have a very, very low chance of dysplasia or cancer. So this is why it's painless, and it's just this very self-limited, it's very benign sort of growth that you see with chronic irritation. That's why you get it. You could see here with the picture that you're getting it along the bite lines. So that's also something to look out for in your examinations. If you see something that shows up along the mucosal bite lines, then you know it's most likely going to be a fibroma. And again, because it's as a result of chronic irritation, you'll see it a lot in the buccal mucosa. All right. So again, taking a look at our pictures, this is erythroplakia, this is a fibroma, this is an oral thrush, and this is a pyogenic granuloma. All right. And these are all the buzzwords that you guys need. So the next question, a 42-year-old man has had a constant bad taste in his mouth for the past month. On physical examination, there are white, fluffy patches on the sides of his tongue. These cannot be scraped off. That's your first clue. A biopsy is taken on a microscopic examination shows squamous epithelial, hyperkeratosis, parakeratosis, and cholecytosis. Immunohistochemical staining for EBV is positive. Which of the following is the most likely risk factor for his oral lesion? Before we read the question, does anyone want to take a guess and tell me what um, what the diagnosis is? Okay. All right, that's fine. The answer is actually the diagnosis would be hairy leukoplakia. Okay, we'll talk about that in a minute. Sorry, 1 second. Let me look at the chat. Leukoplakia. Yeah. Okay. So who knows what the answer would be? So it's either chronic alcohol abuse, diabetes, HIV, pernicious anemia, or Sjogren syndrome. So in this case, it would be actually C, HIV infection. And we'll talk about that in a minute. We'll see why. So this is again hairy leukoplakia. Now, there's a difference between normal leukoplakia and hairy leukoplakia. With hairy leukoplakia, a lot of the time you'll see that it's EBV mediated. Okay, so you'll see that the patient has positive, serology for EBV, or they'll just tell you straight up that immunohistochemical staining for EBV is positive. Now, the thing that I want you to remember about hairy leukoplakia is that it's very, very, rare to happen with somebody who's not immunocompromised. Most likely, they're going to be in patients with HIV. So it says right here in this text, patients living with HIV, organ transplant recipients, because they're very immunocompromised. Okay, so contrast with thrush, again, because this is non-scrapable, so that's how you can differentiate it from oral thrush, although they both present as white patches. Okay, and Candida, you can also get it on the sides of the tongue, but the difference here is that these cannot be scraped off, and this is what it would look like. Okay, that's how you know it's hairy leukoplakia. The classic site is the sides of the tongue. All right, and this is the classic vignette. And 35-year-old HIV positive man presents with a white non-scrapable plaque on the lateral tongue. EBV, and again, coilocytosis, all these things, classic buzzwords for hair leukoplakia. These are again some of the buzzwords that you might see. Okay. All right, let's move on. So next question is, a 37-year-old man presents with a painless ulcer on the base of his tongue that has persisted for the past 6 weeks despite improved oral hygiene. He denies tobacco or alcohol use, but reports a high number of oral sex partners. First clue. Physical exam shows a shallow, non-healing ulcer with indurated borders on the lateral tongue. Biopsy demonstrates severe squamous dysplasia with a loss of epithelial maturation and nuclear atypia. Which of the following best explains the molecular mechanism responsible for this lesion? So let's go over a few of the keywords. So first one, persistent ulcer. Persistent ulcer. No tobacco or alcohol use, but high number of oral sex partners. Okay. Indurated borders, I guess so this would be kind of important. And this is probably the most important, severe squamous dysplasia with loss of epithelial maturation and nuclear atypia. I think this is clear that we know this is a malignancy. This is a malignancy. So the answer in this case would be B, viral E6 protein mediated degradation of P53. So who can tell me what the diagnosis is? Anyone in the chat want to take a little guess? Okay. Close. Close. So this is squamous cell carcinoma. All right. So we know by now that we have a bunch of oncogenes or oncogenic microbes that are related with some cancers. One of them is HPV, which is human papillomavirus. Now it doesn't say so in your guys' slides, but I want you to remember one thing about HPV because it's going to keep coming back to you, for a lot of the blocks. HPV, a lot of the times, especially the oncogenic classes of HPV, like 16, 18, always associated with squamous carcinoma, squamous. Okay, a lot of the times, if you see something and it tells you you have squamous dysplasia, then that should, especially if it's in the oral mucosa, if you see two things that you should look out for, a high number of sexual activity or high sexual activity and squamous dysplasia, that should maybe point you towards HPV mediated cancer or squamous cell carcinoma. So again, this is the table that you guys have. Again, you have HPV associated and non-HPV associated squamous cell carcinoma. So with the HPV associated, they are younger patients, and that's because obviously a younger patient is more likely to partake in, sexual activity. Location would most likely be oropharynx, but again, this can take place wherever there could be sexual intercourse. So it may be cervical squamous cell carcinoma or anything like that in a female. But again, this block obviously is head and neck. Non-keratinizing squamous cell carcinoma. And the pathogenesis are E6 and E7 oncoprotein. They inhibit P53 and retinoblastoma gene. So E6 would inhibit P53, E7 would inhibit RB. The way I like to remember it is 6 comes before 7, and the letter P comes before the letter R. So E6 with P53, E7 with retinoblastoma. All right. And then you have non-HPV associated, which are older patients. Usually they would, have your classic risk factors for any carcinoma, especially if the oropharynx, like tobacco, alcohol, things like that. And this is the pathogenesis is just chemical carcinogen. So there's not really any gene-mediated things. It's just chronic irritation that are causing this dysplasia. Okay. Which of the following shows squamous cell carcinoma? I want you to really, really take a look, take a close look at each of these four pictures. Does anyone want to take a guess? Maybe one. Okay, good guess. So here I actually wanted to give you guys a little trick question. So there's two correct answers here. The answers are 1 and 4. One shows keratin pearls. Keratin pearls, you guys know it's squamous cell. And squamous cell, one of the key distinguishing features about squamous cell, at least some kinds of squamous cells, is that they have a keratinized surface. So if you're gonna have squamous cell carcinoma, you're going to see keratin pearls. You're not gonna see keratin pearls in any other type of cancer. If you see keratin pearls, it's pretty classic for a squamous cell carcinoma, regardless of where it is in the body. Okay, you could have like for example, pulmonary squamous cell carcinoma, which is happening in the lungs. You're also going to see keratin pearls. The second thing are these desmosomes. Those we call these intercellular bridges, and you guys can see these little bridges connecting the cells together. These are your desmosomes. That's also a key feature of squamous cell carcinoma. So if you see keratin pearls and intercellular bridges or desmosomes, this is, immediately pointing to squamous cell carcinoma. These pictures are not in your block, by the way. This is from your neuro block. This is the glioblastoma multiforme. You guys can see the pseudopalisading thing, if you guys remember it. And this is in a third year block. This is called a Scheller-Duval body. It's not important for now. Okay, so again, it's 1 and 4. And again, this is the normal progression of squamous cell carcinoma. This is just to show you. I'm not sure if I don't think you have to remember all of these. I don't think you do, but this is just to show you in certain types of cancers, it's a stepwise, it's a molecular pathway. There's a mechanism for it, and sometimes you'll sort of pack on many mutations to sort of progress the cancer along. So again, you can see here that this is normal. You can see here that you're starting to get some hyperplasia and hyperkeratosis. You'll see the keratin layer is getting very thick. Here you're starting to see a little bit of dysplasia, but you can see the top layer still looks fairly normal. Okay. Here you can see the entire surface of the epithelium is dysplastic. You would call this CIS, which stands for carcinoma in situ. That's basically when the entire epidermal layer would be completely dysplastic. And then you would get invasion. When you get invasion, you start to see keratin pearls. Like you can see here, dysplastic cells in the dermis and in the deeper layers. Here's where you would know that it's a squamous cell carcinoma. All right. Okay, let's move on to lecture 2. So again, there's not many diseases, not that many pathologies in your guys' lectures, so we're going to be moving through these fairly quickly, inshallah. All right, first one. By the way, if you guys ever wanted to do more of these questions on your own, I'm getting a lot of my questions from the Robbins pathology book. So if you guys want to do them later. So, a 67-year-old man with Parkinson's disease has experienced increasingly dry mouth for the last 3 months, and this interferes with his eating and his swallowing. He has noted dry eyes as well. On physical examination, he has minimal tremor at rest, and there are no other abnormal findings. Lab studies show no detectable autoantibodies. Very important. Which of the following is the most likely cause for these findings? Who can tell me? Anyone want to take a guess? We have either alcohol ingestion, anticholinergic drug use, candidiasis, sialadenitis with blockage of the salivary duct, Sjogren syndrome, tobacco use. Who wants to tell me? E. Okay. No, it's actually not E. The answer would be B, anticholinergic drug use. I wanted to put this in there because I wanted to throw you guys off a little bit. I know that it gives you very classic findings of Sjogren syndrome, which are dry eyes, dry mouth. So you would start to suspect Sjogren syndrome. But what I want you to remember about Sjogren syndrome is that a lot of the times it's going to be immune mediated. You'll see here that they showed that lab studies showed no detectable autoantibodies. That's telling you that maybe this is not Sjogren syndrome because you would find some antibodies in Sjogren syndrome. You guys know them by now, your ANAs, your things like that. Okay, so and they did mention that he has Parkinson's, so this is anticholinergic drug use causing a side effect of dry eyes and dry mouth. Okay, but I'm putting this here because they told you xerostomia, which is what this presentation is called, which is decreased production of saliva, dryness, fissuring, and ulceration, difficulty in swallowing and speaking, dental caries, and candidiasis. So these are all features of xerostomia. One of the most common causes is drugs. Another cause of it would be Sjogren syndrome, which is immune-mediated destruction of the exocrine glands. Okay, so I just wanted to point that out. Whenever you guys see symptoms that remind you of Sjogren syndrome, just remember there are more common causes. In this case, would be drug use. Okay. So let's go to the next question. A 56-year-old woman presents with chronic dry eyes and dry mouth for the past 2 years. She frequently uses artificial tears and carries a water bottle to help with swallowing. Examination reveals bilateral parotid gland enlargement. Laboratory's test shows positive anti-Ro antibodies and elevated ESR. A minor salivary gland biopsy reveals lymphocytic infiltration and glandular destruction. Which of the following is the most likely complication of this patient's condition? So is it A, sialolithiasis, B, B-cell non-Hodgkin lymphoma, C, recurrent aphthous ulcer, D, vitamin B12 deficiency, or E, candidiasis? Who can tell me? No guesses? A, okay, not exactly. So the answer here would be B, B-cell non-Hodgkin lymphoma. Now, before you start rolling up your sleeves, I know that you guys haven't taken Hodgkin's or non-Hodgkin's lymphoma yet, but I just wanted to point out that this is a very, very common complication of Sjogren syndrome. You guys know by now that this is obviously Sjogren syndrome. You have all of the same symptoms as the last question, plus this time positive antibodies. So you'll know that this is probably an autoimmune thing. B-cell non-Hodgkin lymphoma, as you can see here, and it does say so in your slides, B-cell lymphoma. This is Sjogren syndrome again. One of the complications is mucosa-associated lymphoid tissue, malt lymphoma, which is a kind of non-Hodgkin lymphoma. Okay, again, it's not really about knowing Hodgkin or non-Hodgkin lymphoma, but remember whenever you have an autoimmune disease, since the B cells are going to be very hyperactive in that area, there's always a risk for some type of B cell lymphoma. And in this case, Sjogren syndrome has a very high, very clear association with the development of a B cell lymphoma. Okay. So sialolithiasis basically would mean salivary stones. So you would see stones in the ducts. And whenever you have the suffix lithiasis, again, obviously this means stones, but typically all of the stones that you see, whether they be nephrolithiasis, sialolithiasis, or even cholelithiasis, which are gallstones, all of them are going to have pretty much the same risk factors, which are stasis of the stones. So it'd be in a patient who's, for example, not eating at all, or starving themselves, then it would get stasis because there's nothing entering the mouth. So the salivary glands and the salivary ducts aren't really working. So you'll have stasis of the fluid, and that would predispose again to stone formation. Okay. And again, aphthous ulcers, we know that they're stress related. B12 deficiency, not even really associated. You would see that more with GI cases. And candidiasis, again, they're not immunocompromised. This patient's not immunocompromised, so it's very unlikely to see candidiasis in this case. Okay, so again, Sjogren syndrome, it's an autoimmune disorder, destruction of the exocrine glands, especially the salivary and the lacrimal glands. Okay, and some of the findings that you'll see here, keratoconjunctivitis sicca, which are decreased tear production and subsequent corneal damage. Again, this is a later complication. Then again, you have the decreased salivary production. And again, the antibodies, very, very important to find the antibodies in Sjogren syndrome. So you have a rheumatoid factor. Again, you can discuss these later on, but just keep an eye out. If you have autoantibodies, and the presentation of xerostomia or Zika syndrome, start thinking of Sjogren syndrome. Okay, and these are again some of the complications to read about. Okay, next question. A 65-year-old woman has noticed a slowly enlarging nodule on her face for the past 3 years. On physical exam, a 3 centimeter non-tender mobile discrete mass is palpable on the left side of the face, anterior to the ear, and just superior to the mandible. Whenever they start describing locations like this, I find it best to just, illustrate on your own face just so you can get a better idea. So they said anterior to the ear and just superior to the mandible. So this is the mandible right here. It's going to be right here. The mass is completely excised, and histological examination shows ductal epithelial cells and a myxoid stroma containing islands of chondroid-like tissue and bone. This patient is most likely to have which of the following neoplasms? So we know by now that this is some sort of ductal neoplasm is related to the parotid glands. It's in the same location, obviously. Okay, I can see some correct answer. Yes, the answer is C, pleomorphic adenoma. Okay, so the word pleomorphic means basically multiple forms, multiple shapes. So you can see here that we have ductal epithelial cells in a myxoid stroma containing islands of chondroid-like tissue and bone. So this is not a very common appearance. If you're seeing this, is basically just means that these cells, they're basically changing shape, changing form. So that's why you would call this a pleomorphic adenoma. Okay. So again, pleomorphic adenoma, it's a tumor of the parotid glands. It arises from myoepithelial cells and represents divergent differentiation. That's because these cells are differentiating. They're showing many different kinds of cells. Okay, painless circumscribed mass at the angle of the jaw. So that's what they mentioned. It's at the angle of the jaw and a very, very high recurrence rate. Okay, I wanted to mention that this is very, very important because one of the main things about salivary gland cancers or neoplasms is that most of them are benign, but they do have some malignant potential. Now, if they were to be malignant, then you would see a very, very characteristic finding of any malignancy, which are of like malignancy of the salivary glands, which is facial nerve involvement. Okay, so if you have a tumor and you would get progressive weakening of the face, and maybe you would get some progressive Bell's palsy. That's telling you that this tumor is spreading and it's a malignant mass now because it's going to be infiltrating the facial nerve since it's in very close proximity. As you guys know, the facial nerve pierces actually through the parotid glands. So, and again, it's very high recurrence rate because it's going to extend through this capsule and it's very close to the facial nerve. Okay. So that would mean that when you're excising this tumor, you would have to do it with very wide margins because it's going to actually extend through the gland capsule. Okay. So again, just like I said, facial nerve palsy is a sign of malignancy. Here are again some keywords, some buzzwords. Sorry to be able to point out pleomorphic adenoma. So it's a painless, slow growing mass, high rate of recurrence because of the capsule extension, epithelial and myoepithelial components. So you see here they said it is ductal epithelial cells and a myxoid stroma. So myxoid stroma, you'll see here chondromyxoid stroma. This is what it would look like. You guys see these cells right here. These are basically cartilage-like cells, so chondroid stroma. Okay, and there is a risk of malignant transformation. One of the main signs of malignant transformation would be Bell's palsy or facial nerve palsy. So the next question is a 39-year-old man presents with a 3-month history of progressively enlarging painful mass near the right jawline. He reports difficulty chewing and intermittent facial tingling. Examination reveals a firm, non-mobile mass in the deep lobe of the parotid gland with mild facial nerve weakness. So, keyword right here. MRI shows a heterogeneous parotid mass with ill-defined margins and no evidence of distant metastasis. FNA, which is fine needle aspirate, reveals mucin-producing cells, squamoid cells, and intermediate cells, and histological grading is a high grade with marked cellular atypia, necrosis, and frequent mitosis. This is cancer, right? So high grade dysplasia, cellular atypia, necrosis. This is a malignant mass, 100%. Let's find out what kind. Following surgical resection and neck dissection, pathology confirms perineural invasion. Just like I said, because this patient is having facial nerve weakness. So again, you're going to be confirmed for perineural invasion. And margins are close but negative. Post-op radiotherapy is initiated. Which of the following histological findings are most consistent with this presentation? Who can tell me? So I haven't told you what type of cancer it is. I just need you to tell me which one of these. Who can? Okay. All right. That's all right. So the answer here is 1. So this is what it is. Again, this is a mucoepidermoid carcinoma. All right. This is the most common malignant salivary gland tumor. Because again, the word carcinoma means that it is in fact malignant. And you can see here, even by the presentation, this patient has facial nerve weakness, and on histopathology, you can see the cellular atypia, the necrosis. This is classic malignancy. Mixture of mucinous, squamous, and intermediate cells, another buzzword for mucoepidermoid carcinoma. And it's very painful, and it has the facial nerve involvement. And there's a very high risk of recurrence. That's because these cancers are typically very high grade. So you can see here, and this is what it would look like. You would see all the atypia, these weirdly shaped cells, and you can see here the different kinds of cells. So again, this is where you would see the squamous and the mucinous and intermediate cells. So again, these would be the mucinous cells. These would be the squamous cells. So it's a mix of all these cells. All right. This is mucoepidermoid carcinoma. Here's a very helpful picture. I actually use this picture a lot to to study back when I was doing head and neck, because it's a very simple algorithm. If you have an acute swelling and it's constant and it's painful, then it's probably sialadenitis, either suppurative, which is bacterial, or viral. Okay, and that's because, and it's acute and it's constant, this is an infection. Okay, and if it increases with eating, then this would be sialolithiasis. Again, secondary most of the times is stasis. If it's a chronic swelling, it could either be autoimmune, chronic sialadenitis, or a tumor. Depends on whether or not it's diffuse, it's circumscribed, or if it's bilateral, then of course you would know that it's autoimmune. Okay, let's move on to lecture 3, which is dental diseases. So the first question would be, what is the most common complication of untreated gingivitis? This is super easy. You guys should get this right away. Yep, exactly. 2. Okay, so I actually made this as simple as possible just to show you guys that this is what gingivitis looks like. Okay, you could see the inflammation here along the teeth line and the gums. So this is gingivitis. Sometimes gingivitis can present as gingival hypertrophy. Most of the time, probably secondary to a few drugs. And again, if this goes very untreated, you're gonna have what some people call it chronic gingivitis, but it's most commonly known as periodontitis. And this is because obviously this inflammation would sort of cause destruction of the gums, and just have halitosis. You would have very loose teeth, and it's just not a pretty sight. So this is what it looks like. Okay, next question. A 19-year-old woman has noted swelling in the back of her mouth for 2 months. On dental examination, she has an area of swelling in the location of her left third molar. Dental radiographs shows a radiolucent unilocular, circumscribed cyst surrounding the crown of the unerupted third mandibular molar. So very important. The lesion is excised, and on microscopic examination, the cyst is lined by stratified squamous epithelium and surrounded by a chronic inflammatory infiltrate. What is the most likely diagnosis? Does anyone know? Okay. A little bit unsure there, but yes, it is B, dentigerous cyst. The probably, I'm not gonna say the only thing, but the most important thing, and like important by a long shot, is that these cysts typically arise from unerupted teeth. So in this case, they told you that there's an unerupted third mandibular molar. If you see a cyst surrounding an unerupted tooth, it's most likely going to be dentigerous cyst. Okay. Then you have ameloblastoma, which is the second most common type of tumor, and it causes basically the histopathological finding would be a palisading epithelium. Then you have what's it called? Odontogenic keratocyst, which is aggressive growth and recurrence with incomplete excision. Odontoma, which is the most common. So again, this is the second most common. This is the most common tumor with dental and enamel deposition. And then you have the periapical cyst. I'm not going to say too much about the periapical cyst for now, because we're going to talk about it in the next slide. So again, the periapical cyst, here are some buzzwords. This is what it would look like. You can see that it's periapical, which means that it's right on the apex of the tooth. And you can see here that it usually arises on the apex of the non-vital tooth. Now, this is non-vital It could be many reasons, but the most common would be an inflammatory origin. So you're going to have either dental caries or odontitis, odontitis, or trauma. Okay, and again, it would be the apex of the roots, and this is what these cysts would look like. Then you have OKC, which is again odontogenic keratocyst, and it is in the posterior mandible, parakeratinized stratified squamous epithelium, aggressive with high recurrence, okay, especially with incomplete excision. Then you have the odontoma, which is the most common. Again, like I mentioned, there's going to be a lot of dental, a lot of enamel. That's why it's going to be picked up. It's going to be very high, basically appearance on the X-ray, and that's because it's very high, highly powered. And then with the dentigerous cyst, which we were just talking about, you can see this unerupted tooth here. And then arising from it, you'll see the cyst. You can see the cystic space right here. Again, this is associated with an unerupted tooth. Okay. These are just the main lesions in this lecture. There's not much there. So moving on to the very last lecture, you have the laryngeal/nasopharyngeal lesions. So starting with the first question, a 28-year-old man who was a singer/songwriter has been experiencing hard times for the past 3 years. He's played at a couple of clubs and nights to earn enough to avoid homelessness. He comes to the free clinic because he has noticed that his voice quality has become progressively hoarser over the last year. On physical exam, he's afebrile. There are no palpable masses. He does not have cough or sputum, but has been advised on previous visits to give up smoking. So which of the following is the most likely to produce these findings? This is super, super simple. I'm expecting all of you to get it correct. Yes, it is C, reactive nodule. So again, what is a reactive nodule? A lot of people call them Singer nodules, and these are basically just hyper reactive, hyperplastic nodules that you would get with chronic irritation. Most commonly, most classically, you would see these in a singer. So the classic vignette of a patient with Singer nodules would be a 20-year-old woman, professional singer, 6 months history of hoarseness, denies dysphagia or infection. Her voice becomes worse by the end of the day and improves with rest. So this shows you that there's some sort of, uh, it's worse with usage of her voice, which is again why it's called a singer's nodule. On laryngoscopic exam, there are bilateral small nodular lesions located at the junction of the anterior and middle third of the true vocal cords. And again, very important that you know that these are fibrovascular nodules with hyperplastic stratified squamous epithelium. Okay. And again, this is what it would look like. These bilateral small nodules, completely benign, no risk of malignancy. You would just get them secondary to singing or any chronic irritation. Okay. So the next practice question. A 6-year-old boy has had increased difficulty breathing, and the character of his voice has changed over the last 3 months. Endoscopic exam shows three soft pink, not sure what this word is, on the true vocal cords and the subglottic regions. Masses are 0.6 to 1 centimeter in diameter. Microscopic exam of the excised masses shows finger-like projections of orderly squamous epithelium overlying fibrovascular cores. Immunostaining for human papillomavirus 6 antigens is positive. Important. Based on these findings, which of the following statements is best advice to give the patients of this boy? Is it A, a total laryngectomy is necessary? B, congenital heart disease may be present? C, the boy should not overuse his voice? D, the lesions are likely to recur? E, therapy with acyclovir is indicated. I'm seeing some E's and I'm seeing some D's. So the answer in this case would be D. Okay. Now this is classic for a papilloma, squamous papilloma. Who can tell me what the likely laryngoscopy finding of the same case would be? No, it's actually two. So this is what it would look like. This is a classic presentation of a squamous papilloma. Now, I mentioned before, It's called squamous papilloma because HPV, actually all of the time is going to be causing some sort of squamous neoplastic changes. Okay, in this case, it would be HPV 6 and 11. Again, these are low risk HPV classes, not typically associated with any malignancy, but in this case, it is a neoplastic growth and it's papilloma. Okay, so very often they're going to be recurring. That's why the answer to the last question was these lesions are likely to recur. And again, they grow on the true vocal cords. They have a raspberry-like growth. So this is what it looks like. You see the way that it's very vascular. It's a papilloma. It's a papilloma that's very vascular. So we call this a raspberry growth. Progressive hoarseness, ulceration, recurrence, and carcinomas are very rare. Again, that's because these are the lower risk classes of HPV. Okay, vertical transmission of HPV in children, preventable by vaccine. Okay, this is why we're trying more and more to get all of these preteens to get vaccinated for HPV. Okay, so here's, I think, one of the last practice questions of the session. A 52-year-old man bothered by increasing hoarseness for almost 6 months now has an episode of hemoptysis. On physical exam, the lesions are noted in the nasal or oral cavity. There is a firm, non-tender anterior cervical lymph node. The lesion shown in the figure is identified by endoscopy. So just take a closer look at this lesion here. Okay. The patient undergoes biopsy followed by a laryngectomy and neck dissection. Which of the following etiological factors most likely played the greatest role in the development of this lesion? Who can tell me? Okay, not that many answers. That's fine. So the answer is actually D, smoking tobacco. Okay, so who can tell me what this is? So again, hoarseness for 6 months, now has an episode of hemoptysis, and what else? No lesions in the nasal or oral cavity. So this is not a nasopharyngeal lesion. Okay, this is a laryngeal lesion. Can you tell me what this is? Carcinoma. Correct. So this is laryngeal carcinoma. Um, it's highly associated with HPV. It is, and I know some of you guys probably thought that this answer would be B, but that's actually only 15%. In reality, smoking has the highest risk of carcinoma. Okay, with laryngeal carcinoma. That's why it's smoking tobacco. Here's the answer. 2% of all tumors, again. So laryngeal squamous cell carcinoma, very, very, very highly associated with smoking. It probably has the highest, or smoking is probably, has the highest risk factor of laryngeal squamous cell carcinoma. HPV can cause it. And I guess we know that it's a squamous cell carcinoma. And again, you can see here the keratin pearls. That's how you know that it's squamous. This is what the laryngoscopy would look like. Okay, but it's only associated with 15% of the cases. The rest of the cases, most of them are going to be due to smoking. Okay, and again, you would have the normal symptoms that we know from cancer, any sort of growth that happens in your larynx, which are hoarseness, things like that. But there's also, since it's a carcinoma, since there's going to be local spread, it also could cause ulceration and hemoptysis because it could ulcerate in that all that blood can go into your airway and you can cough up blood. Okay, I think this is our last practice question. A 45-year-old man from southern China presents with nasal obstruction, epistaxis, and a painless neck mass. Okay, he also reports recent hearing loss on the right side. Physical exam reveals unilateral cervical lymphadenopathy and fullness in the right nasopharynx. MRI shows a mass in the nasopharyngeal vault with local extension. Biopsy of the lesion shows poorly differentiated squamous cell carcinoma with a lymphoid-rich stroma. Which of the following is most strongly associated with the pathogenesis of this patient's condition? So keywords there: China, lymphadenopathy, hearing loss, squamous cell carcinoma. The answer here would be B, EBV latent infection. Okay, and this is again nasopharyngeal carcinoma. So sort of to contrast with a lot of the oropharyngeal and laryngeal carcinomas that we have, this is not really associated with HPV. It's actually more related with EBV. especially with types 2 and 3 carcinoma. Okay. Distinctive geographic distribution. So pay attention to this on any examinations. If you have a patient from South China, children from Africa, then a lot of the times it might be pointing you in the direction of nasopharyngeal carcinoma. Okay, and this is because EBV actually can be considered in some cases an oncogenic microbe because it activates the this pathway that you guys know, of course. It's one of the precancerous pathway, and then the epithelium would go some malignant transformation. Here's just a summary that I have of all head and neck cancers that I got from first aid. I definitely think should go through it. So it's mostly squamous cell carcinoma. Okay, risk factors would include tobacco, alcohol, HPV 16 in oropharyngeal, and EBV in nasopharyngeal. So you guys can see here the difference. Again, and laryngeal papillomatosis, which is what we talked about previously. This is the same thing as saying squamous papilloma, also called recurrent respiratory papillomatosis. So associated with HPV, just like we know, stratified squamous epithelium, such as the true vocal cords, especially in children. Okay, so just read through this whenever you get the chance. It's very helpful. All right. And that's it for my session. I know that it was a pretty short one. I hope you guys can, if you'd like to watch this before your exam, it's a pretty good review of all of your lectures, inshallah. Please don't forget to scan the QR code and let me know how I did. If you have any feedback, please go ahead. And yeah, thank you guys so much for watching, and we'll see you next time, inshallah, in the next PAL. Have a good day.